Samia Hurst for this series. It's a very important topic. We are all dealing with personalized data, and ethics and data protection seem to constitute the largest problem and hurdle we are facing. It's not so much the technical details, it's all the regulatory ethics and data protection stuff that makes it complicated to do joint research. And from that perspective, it's a utter pleasure to have you here, Samia Hurst, for this presentation. It's a welcome address. I'm really curious about it. You're a professor in Geneva, physician, bioethicist. So this is a very great combination because it's covering both sides, the research part and the regulatory part. And you're also in the COVID task force, the vice president, and in the National Ethics Committee on Human Research. So you have all the prerequisites that let us expect an intriguing presentation with all the stuff we need to know about ethics, how to proceed in personalized medicine. That's a very short introduction, but I think you will show us so many things that I don't want to cut your time.
Thank you very much. Thank you very much for the invitation. I'm very happy to be here. Precision medicine is pretty exciting and data sharing is pretty exciting. And one of the things that happens when we humans get excited is that we are willing to make sacrifices. And as long as we sacrifice our own time, perhaps our resources, our private life, and so on, this is one of the things that happens in research. We could have a different talk about that, but at least it's allowed. This is fine. We are allowed to sacrifice our own stuff. The problems start when we are willing to sacrifice others, when we are willing to sacrifice the interest or protection of what belongs to others. And in thinking about what I could give you as a send-off for your symposium in the first half hour, there are so many things to say. I really didn't want to lead a marathon through all the different aspects. I decided to focus on just one thing. And I think the just one thing I wanted to give you as the beginning of your day is the importance of confidentiality, of privacy, because I do realize that data protection is a hassle, that it is easy to lose sight of why it's there. And it is important to know why it's there, because I agree that sometimes there has to be adjustments, sometimes rules change, but it is important to know the underlying principles in order to keep respecting them, and also in order to know where tensions might arise. So I'm going to speak under the provocative, perhaps, title of "We Have Something to Hide." The importance of confidentiality in a transparent age, because I believe this is the main risk actually in precision medicine, that we might lose track of the importance of confidentiality. So first, transparency. Transparency, you see it everywhere. You see it mentioned in a positive light. If you go simply to Google and look at what comes up first, you see the Wikipedia article for transparency as used in science, engineering, business, the humanities, and in other social contexts, etc. Transparency implies openness, communication, and accountability. It is a positive value. And there are NGOs that work for transparency, that work against injustice and corruption by promoting transparency. It is a positive value, mostly. But at the same time, we also have a special case in medicine because of something quite basic and fundamental, actually. If you look at the sources of medical ethics, which also in our culture happen to be the first sources of professional ethics, all professions considered, what do you find in the origins, as it were, of our in-house ethics of medicine? You find the Hippocratic corpus. And the very first principle that most people remember when you ask them what is in Hippocrates is this very, very famous first, do no harm. Why is it there from the beginning? Well, because medicine was able to harm at once and only much later became able to help. Luckily, we have become able to help, but we have remained able to harm. And so it was important, it was healthy in a way to start off with this principle of, well, at least if we cannot help, let's not harm people. Another principle that is in the Hippocratic corpus, which looks like it's the same on the face of it, but really is rather different, is another famous dictum: the patient's good will be my highest law. Why is that there from the beginning? Well, the tools of medicine have been powerful from the start, for good or ill, and it must have crossed the minds of the first patients and the first physicians that it was technically possible to use them for other goals than the patient's good. So imagine that you are a very rich and old person with impatient heirs, and you call upon a physician to cure you because you are ill. You have to be able to trust that the physician will not send you off faster because your heirs have promised more money. And so you have, in order to entrust yourself to medicine, you have to be able to trust that your good will be the highest law, that medicine will not use its tools against you rather than for you. And then much later, this is no longer in Hippocrates, you have another principle that emerges, one that required physicians to be sedentary in order to emerge, because once they became sedentary, once they stopped wandering from town to town, then they began seeing all the patients that were not brought to them. And when they started seeing them, then another principle emerged: equity in access. Medicine does not evaluate persons by their fortune or identity, but promises help equally to all who implore its rescue. This is, of course, a very drastically summarized version of medical ethics, but I present it to you here because it enables me to summarize it yet further and remind us that the very first principle of medical ethics is more or less: thou shalt not abuse the power needed to practice your art. When we practice a profession, when we practice in a job that is aimed at helping those who are in need of help, so those over whom we have power, this power has to come with rules for the good use of this power. And of course, whenever power is being used, the very first rule is to not abuse it. And that is why the cornerstone, as it were, of all professional ethics is that no abuses of power of those who must have power in order to help. Power is neither more nor less than the ability to influence somebody else's future. And so, of course, in helping professions, we must have some, otherwise, what are we for? And so we have to also endorse rules to not abuse it. This is why you have texts like this in the Hippocratic Oath. This text, a very famous passage, which in the same breath almost establishes medical confidentiality and also a ban on sexual contacts with patients and their household members. These two principles look very different from our contemporary vantage point, but in fact, they are both bans on the abuse of power, on the abuse of a situation where we must know very private things about our patients, where we must have access to the insides of their homes, to their naked bodies, etc. And in both cases, we are forbidden, we swear to not abuse the situation. This is also why professional ethics has the shape it has. Professions exist to serve those more vulnerable than the professional. They can only exist with an explicit constraint against abuses of power. And in a way, this is what professional codes are. Professional codes are the explicit promise not to abuse the power entrusted to professionals. And this is the root of medical ethics. This is why we have this series of bans that look very different from one another. Doctors are not allowed to use the instruments of medicine against patients. We are not allowed to participate in the death penalty or torture, to force feed competent persons, to detain political opponents of our governments in psychiatric institutions. We're not allowed to sell unindicated medicines, for example, for personal gain, or to practice unindicated interventions, for example, for personal gain. And we're not allowed to use confidential knowledge for anything other than the patient's good. And we're not allowed to seduce patients. There are exceptions, but these exceptions are very strictly regulated. So, for example, psychiatrists can be called upon by courts to testify on the dangerosity of prisoners. And in this case, they're called upon to use the tools of medicine, namely diagnosis and prognosis, in the service of the safety of society rather than in the service of this person. And this is why this is not a therapeutic encounter. There is no doctor-patient relationship in this case, and the patient has, the detainee in that case has to be warned of it. So this is this very unusual situation where a doctor has to tell the person who is not his patient you have the right to remain silent, and everything you tell me in this encounter can be used against you in a court of law. Unusual words in the mouths of a clinician. So we have something to hide, first and foremost, because divulging patients' information could represent an abuse of the power that we hold, the power needed to practice our art. And this is the first reason why confidentiality in medicine matters. But it's not the only reason why. The other reason is that confidentiality matters, period. Confidentiality, or rather the existence of a private sphere and the distinction between what is known there and what is known outside, privacy, in other words, is one of those things that ethnologists called a human universal. Every culture has it, not to the same degree or regarding the same things. Very notoriously, social taboos are not the same in every society, but there is such a thing as privacy in every society. Confidentiality matters because revealing confidential information can expose persons to harms. It can be misused, in other words, but that's not the only reason. Even when there is no harm done, even when we know in advance that there will be no harm done, it is not the only reason why confidentiality matters. We must remember that it sits on many different layers of reasons, and even if one of them is gone, it doesn't mean the others are gone as well. Confidentiality also matters because revealing confidential information can shame persons, even if no harm is done. Confidentiality, in a more subtle way, but just as important, preserves the possibility of individuality. What do I mean by that? I mean by that the fact that when we present ourselves in public, there are conventions involved. Every society has some conventions. Here we are on Zoom, so many of your videos are switched off. And I don't know how you present yourselves behind the switched off videos. If we were in a room, a seminar room of the usual kind, probably we would all look a little similar. Probably an anthropologist from Mars who just landed there would recognize that we are all members of the same tribe. I suspect nobody would be wearing something completely bizarre, an orange unicorn disguise or something of that kind. We would look familiar, we would look similar, probably more similar than we actually are in our private lives. And this is precisely what I want to get at. Our private lives enable us to live experiences of humanity that we might not experience if we had to live them under the gaze of everyone all the time. Now, when I say this, people's minds go to strange places. So let me hasten to give a completely innocent example. One of my nieces is in her 20s now, and she is a virtuoso unicyclist. But she is also a rather shy person, and she was even more so when she was younger. And when you learn the unicycle, there's a stage where you are a little ridiculous. You fall, you are not very good at it, it doesn't work. And if she had had to practice under observation, she would never have learned. She needed to be on her own without anyone watching for this stage of learning a skill, which brings her great joy today. And so we all have things like that in our lives. We all have things that need to be hidden in order to exist, simply, and sometimes to exist before being shown to others. Confidentiality also enables relationships. We reveal different things to different people. We show trust by revealing things to someone that others do not know. And this is a way of establishing some kinds of relationships, to tell things about us that we do not share with everyone. And this is another value of confidentiality. And finally, because confidentiality matters for all these reasons, it means it matters to people. And because it matters to people, it means that they will not reveal things to us, health professionals, if they believe that we will disclose them to everyone else. Another way of putting this is people would not get undressed in medical consultations if medical clinics had glass walls. They also would not reveal things to us if they thought that we would tell them further. And this is actually being tested in situations where health systems push this to the limit. So we are all aware probably that if you go on medical rounds in a normal clinic, patients are not alone in their rooms. And when you discuss their case in their presence, the neighbors can hear. So this is a transgression of confidentiality, which happens daily in our hospitals. And people are uncomfortable with that. And they realize that the logistics don't really allow anything else. And so researchers have looked at what happens in such cases. And if you ask patients, well, does it bother you when medical rounds come and people can hear? Our patients are really very kind. They forgive us a lot. They tell us, no, we know, we understand, it doesn't really work in any other way. But then the researchers have to be smarter than that. And they asked a little further down the line in the questionnaire, well, when it's your turn and you have to talk about your case to the doctors and nurses, do you tell them everything? And here the patients say, oh, of course not. I know the others can hear, so I don't tell you everything. This is this last point. It's not only about whether people are upset, it's also about whether they then withhold information because they take into account the fact that confidentiality is not being entirely respected. So confidentiality matters, and it means we also have something to hide, not just because divulging patients' information could represent an abuse of power, but because our patients care about confidentiality for many reasons, and usually rightly so. If we do not hold it, if we do not value it, if we do not perform it, they will stop trusting us and trusting us with their information. The next reason is that, well, we know a lot. We know a lot, and this has increased in recent years, of course. This is a meme I took out of the internet. It's a few years old already, but I think it's really illustrative. It's this picture with the following legend. When I was a kid, folks were terrified that the government would put microphones everywhere. Today, folks ask the microphone if cats can eat pancakes. We know a whole lot, and precision medicine can also yield a whole lot of information. That is precisely why it's exciting. We can find things out, things about persons, things about populations, clinical information, non-clinical information, stuff we asked about, stuff we didn't ask about. We have incidental findings sometimes, answers to questions that were not asked. We find out new questions. This is why it's such a great field of science, but it means that yes, we will learn a lot, but then we will know a lot. And this also comes down to, well, what will we do with the stuff we know? And here I think one of the central concepts that clarifies part of the difficulty we are in is the concept of trust. People entrust us with their information. And here the most interesting thinker in recent years, in my view, is a British philosopher called Dame Honora O'Neill. And she starts with the problem of trust in our societies to give us very interesting clarifications on why trust matters and what it is. Here's what she says about transparency and trust. Our revolution in accountability has not reduced attitudes of mistrust, but rather reinforced a culture of suspicion. Instead of working towards intelligent accountability based on good governance, independent inspection, and careful reporting, we are galloping towards central planning by performance indicators reinforced by obsessions with blame and compensation. This is pretty miserable, both for those who feel suspicious and for those who are suspected of untrustworthy action, sometimes with little evidence. And here she puts the blame squarely on the confusion between transparency and trust. So if trust is not about transparency, if trust is something else, then what is it? And here's what she says. She says, well, trust should not be confused with transparency. It should not be confused with friendship or affection either. It is quite possible to trust someone you don't particularly like. It is very possible to not trust very much someone whom you very much like. Trust is not entirely blind. It is never entirely given. It is very specific. In fact, we don't just trust, we trust that. We trust a specific person or group if we believe that they will do a specific thing in a manner that is competent, reliable, and honest. Now, let me give you an example because this is a little abstract. I'm a healthcare provider. It was said in the introduction, and in our lives, in our biographies, there is always this point where you are swallowed by the hospital. And many of us emerge with social networks constituted mostly of other healthcare professionals. I think you know what I'm speaking about here. And it was my case. And it means I know many colleagues, many colleagues who are friends, and I'm married to one and so on. Now, among this social network, I'm happy to say that there are many people whom I would entrust with my life without a second thought if it needed saving. But among the same people, I do have to say, there are some whom I would not entrust with a letter to put in the mail. And I know you know what I'm speaking about here. We trust specifically. Trust is about predictability, and it is about specific things. Now, what does this mean? It means that we have to know what we are entrusted with if we are to make good on the trust. We also know this as healthcare professionals. As a physician, I have seen patients come to me many times with an implicit trust that I would more or less make them immortal. They didn't really say it like that, but they trusted medicine to set aside the danger of death, whatever happens to them. Now, this trust I cannot take because I am not able to make good on this expectation. And it means that in order to manage trust reliably, trust in a trustworthy manner, we have to know what people trust us for and be able to distinguish between what we're able to do and unable to do. If we're unable to do it, we have to make it clear. We have to refuse the trust. If we are able to do it, then we should do it in a manner that is competent, reliable, and honest. And so the question to ask in any field, and I think it's a very important question in precision medicine and data sharing is, well, what are you trusted for? Because if you do not know, then you may be in trouble. If you do not know what you are trusted for, then you may be implicitly accepting expectations that you cannot fulfill. You may also be vested with expectations that you could fulfill, but since you do not know, you are not taking the adequate steps in order to make sure that you're able to do it in a manner that is competent, reliable, and honest. So in the case of data sharing, we actually ran a study based on citizen panels in Geneva a few years back, just before the pandemic, luckily, because it involved getting a lot of people to meet in indoor spaces and would have been hard nowadays. And one of the questions we asked them was, well, who would you share your data with and for what purposes? And we realized that the answers, it was, of course, not everybody gave the same answer. They discussed them, we recorded the arguments, we coded the arguments, and there were disagreements among the groups. They were not all on the same page, of course. But the trends that emerged, the themes that emerged, rather mapped this account of trust in an interesting way. There was great trust in the health system as long as data was shared in order to find things out that would help to take care of people's health in the future, my own as well as others. And there was a great trust that this is what would happen. Research for the common good centered on health had a very high level of trust, and there was trust that this would happen as long as data remained in the public health system. Whenever you left the hospital, trust sort of fell off a cliff, and it did so for different reasons. So people were less willing to share their data with the pharmaceutical industry, and in the arguments, the reason was that this was an agent that was trusted, a partner that was trusted to be competent, but it was not trusted to be doing things for the common good. And this, in a similar way, but for different reasons, trust also dropped off a cliff when you went in another direction towards patient associations. They were trusted to do things for the common good, but they were viewed as amateurish. They were viewed as less reliable and competent. And so this is what I mean when I say that it fits the pattern here of why we trust. We really do want all of these conditions to be cumulative, to be fulfilled. But if we do not know what we are trusted for, if we do not know what people expect and what they expect of the partners whom we share the data with, then we are unable to do this very important thing, which is to guarantee through the data sharing contracts that the trust we accepted initially will remain reliably fulfilled down the line when we share the data. And I think this is one of the major difficulties facing data sharing today, is that we are often in the dark about what people really expect when they entrust us with their data. And also there is the matter of incidental findings. Persons have the right to decide which information to integrate into their lives and when, and their lives here means their whole lives. And when answers arrive to questions that were not asked, things get difficult. So this issue arises whenever there is the possibility of giving information back to people who gave us the data. And this actually exists technically whenever data is encoded rather than anonymized, when we know whose data it is. And this also is not always clarified initially. How will the return of information happen, if at all? Is it clear that it will not happen? Should we make it clear that it will not happen? Will there not be cases when we really think it ought to happen, even if initially we said no, etc.? There is, in predictive medicine and in situations where diagnosis can yield incidental findings, such a thing as a recognized right not to know. Self-determination implies the right to say no. And this includes the right to say no to obtaining information, although of course this is harder to implement than the right to say no to an intervention. And there are in fact diverse wishes regarding whether to self-test for predictable diseases. And this has been studied abundantly in the first area of predictive medicine, perhaps namely clinical genetics. And in this area, there was a really interesting study, which is no longer new now, but which really shed light on a central point that I want to make today, where researchers interviewed persons who had the choice whether to conduct or not conduct a genetic test for a severe disease. And some of them had decided to do it, others had decided not to do it. And the researchers asked them, well, how did you decide whether or not to know? And the really interesting thing is participants told them, actually, that's not the question. The question is not whether or not to know, the question is when to know. And they spoke of incorporating the decision into their biographies, of deciding to know when it could be actionable. And sometimes the stories they told about deciding whether or not to know and when to know went back several generations. It was not even just about their personal stories. So what to do with an unexpected finding? Well, do you ask ahead of time? Do you ask about everything that could happen? Do you decide for patients when the information arrives? And well, what do you do about self-determination then? And a growing approach is to provide actionable information, but then what is actionable? You can either make a list of it and announce it, or you can establish categories to enable sufficiently informed consent. This is one of the things my team is working on, and I see time is passing, so I'm not going to go very much deeper into this. So we have something to hide also because our patients do not always want to know all the answers all at once. Sometimes they want to know later. And then there is the matter of the effect of information on identity and stigma. And we know that even respectful consented disclosure can expose people to risks related to respect, risks related to their autonomy. There are risks of identity harm, stigma, job loss, infantilization by others, greater reliance, etc. And also the confrontation, perhaps, and this may particularly be the case in the situations of rare diseases, which are precisely an area where precision medicine is so interesting, confrontation with needs that society has neglected, which sends the implicit message that, well, our organization that we spend so much money and time on, it was basically not for you. And this also sends the message, you are not worthy. And this is a key element of how medicine and society interfaces that needs a lot more work and a lot more attention. So we have something to hide also because there can be individual and collective side effects of what we find out. Stigmatization is important to take into account. Information does not fall on neutral ground. And when it aligns or seems to align with pre-existing stereotypes, risks increase. And this can happen even when we give collective information, even when individual confidentiality is maintained. If we publish a result about a social group, then this group, especially if it is already marginalized or weakened, might get a kind of double whammy from the information. We have to take into account the social context into which the information lands. And if you want to learn more about stereotypes and stigmatization, there is this really interesting self-test you can do on the Harvard Implicit Project, looking at implicit biases and stereotypes. So we have something to hide because we know a lot, including things that can reinforce risks of individual and collective identity harm. So in summary, ethics in any field is like a kind of very strange instruction manual. This is, of course, a spoof here on the IKEA instruction manual for the border wall for President Trump, former President Trump. But ethics is not like IKEA instruction manuals that can very famously be exported anywhere and follow the tool anywhere, and it's always the same instruction manual with the pictograms. Ethics is not like that. It's an instruction manual that is about not just the tool itself, but the deployment of the tool in a specific social context. And this is why you have to take into account also where the information that we learn lands, what is going to be done with it. Again, to borrow from genetics, if you do a genetic test in a society that protects you very well against misuse of genetic information, the risks are not at all the same as if you do the exact same test with exactly the same parameters, but in a society that offers no such protection. Ethics is an instruction manual about the proper deployment of a tool in a given context. And that is why we have to integrate it in our context every time. Thank you for your attention.